Kendall, who is here from Oxford, a research fellow from Warwick, sorry. And we will be talking about the NHS Test and Trace app, but she will also tell us a little bit about her academic video, which looks an interesting turn. So yeah, I'm handing over to you.
Thank you very much. Yes, thank you so much for inviting me and for organising this. It's wonderful to be here in person. And this is my first hybrid talk, so I hope it all goes okay for people watching online. And I would welcome constructive feedback if there are ways that we can make that work better in the future. But yeah, here we go, let's try it. So, oh, does this work? Yeah, lovely, thank you. Yes, so it's a Women in Maths seminar, and I do think it's important that, as well as talking about maths, it's great where we can to share certain things about our lives and our careers and how we got to where we are. And my career trajectory has been fairly unusual, through pure maths, through cryptography, trees, HIV, and currently I'm working on COVID-19, and presumably that's not going to be forever. So there will hopefully be more twists and turns along the way. Please. And in amongst all this, I've had 2 career breaks for maternity leaves. I've also done shared parental leave. And I know that back in 2005, when I was studying pure maths at York, these were things that I thought it wasn't the done thing to change field. It was really damaging if you took a career break. And those were things I was quite worried about. And I can't speak for everyone. I know for some people they are very tricky things to handle. In my experience, it's been really positive, and I'm very happy to chat about my reflections and my experiences of how those things have worked positively for me. So catch me afterwards or email me or anything. I'm really happy to talk about that.
And the trees, sorry, the trees are real trees or mathematical trees?
Biological, evolutionary trees. Yeah. Good question, thank you. So today I'm going to be talking about the NHS COVID-19 app. So I'll start with some motivation, why contact tracing is a good idea and why via an app. Then I'll talk about the epidemiological impact of the app and ways that we can try to measure that. And finally, just briefly, I'll talk about some epidemiological insights that have actually come out of the app. Okay, so we'll start with motivation. So contact tracing is a well-established public health intervention that's been going for a couple of 100 years. The aim is to identify individuals who may be infectious, who are at slightly more risk than the general population of being infectious, because you think they've come into contact with an infectious person or individual or water pump or whatever it may be. And usually the point of doing that is to do some combination of these things to inform them of their risk, to direct them to testing if that's available, to direct them to treatment, and often with some pathogens, the sooner you can start treatment, better. And in some cases to tell them to isolate so as not to pass it on. And it's a common intervention for things like tuberculosis, measles, HIV. And I was working on HIV at the time when COVID struck. And it's a powerful intervention. It's credited as a key part of the eradication of smallpox, just towards the end when it was just kind of popping up in small pockets. They do intense contact tracing to get rid of that pocket of smallpox circulating. And contact tracing was really powerful in that. And in SARS-CoV-1, you may remember the SARS epidemic in 2003, that was essentially controlled through isolating people with it and contact tracing and isolating those people as well. And as well, while you're doing that, you can gain insights as to who's infected whom, what the demographics are, who is spreading the disease, and you can actually learn things by your contact tracing as well. So this isn't the case for all infectious pathogens, but for many, you get infected and you're not really infectious yet, and then somehow as time passes you become more infectious, and you usually your immune system kicks in and you become less infectious over time. Not always the case, but COVID tends to follow this kind of pattern. And if the y-axis is the number of infections that are being caused, the area under this curve is that number R0. That's the, on average, how many, if you're an infected individual, how many other individuals are you going to infect on average? And the thing about SARS-CoV-2, COVID-19, is that the time when your symptoms start, if you get any symptoms at all, is somewhere around, there's quite a lot of uncertainty, but somewhere around the peak of your infectiousness. Okay. Now, happily, so R0 is technically how many people an average individual would infect when there's no interventions and it's a completely susceptible population. Happily, we don't tend to see that in the wild very much, because happily we tend to bring in interventions and, well, and then also people start getting infected and you don't get to observe it typically. So then we can talk about the effective reproduction number in the presence of interventions. And here is just a sketch, but if you imagine that you asked everybody, once they got symptoms of COVID-19, self-isolate, then your curve would look something like this. They're infecting the original number of people until they get symptoms, and then it drops down. But the reason that that doesn't go straight down and flatline is because people will be sort of imperfect about their self-isolation, and not necessarily any fault of theirs if they have to go home to susceptible people. And as I put in the talk, many people, probably roughly a third of people, the original Wuhan strain, don't show any symptoms at all. So you're always going to get some contribution of infections from people in that's half of the curve, even in this intervention. And the important thing that we were commenting on really early in the pandemic was that because there's such a large area in this half of the curve, if your R0 is greater than 2, say, then to bring RE below 1, which is the condition for controlling the epidemic, then you're going to have to do something about this front half of the curve. So we were running those numbers. If you can cast your minds back to this time 2 years ago, there was very little data really, but the sort of data we were getting, do you remember the Diamond Princess cruise ship? There was some data coming off that, and from the early data we could already see the routes of transmission, and we could see that there was quite a high burden of infections coming from people who weren't showing any symptoms at the time. Possibly half of all infections were coming from people not showing symptoms at the time. And because of that, we articulated that it was going to be important to use contact tracing to help attack that first half of the infectiousness curve. It was going to need to be fast because the time between being infected and reaching your peak of infectiousness is short. It would need to be scalable so that if lots of people were getting infected on the same day, you could still contact trace for all of them. And you would need to be able to notify random contacts. So there's sort of informal contact tracing, right? And I'm one of many people who got infected over the Christmas holidays, and the first way we found out was WhatsApp, because everyone was just telling each other we've been in contact, and that can naturally happen. But if you want society to function as normal and you want to be able to go on public transport and meet random people in your day-to-day life you don't necessarily have contact details for, then you're going to need to be able to do it well and anonymously as well, so there's no shame involved in telling people you've got it, you've maybe passed it on to them. And so for all of these reasons, we suggested that, yeah, because of the way it was spreading, that contact tracing was going to be important and that it would be worth developing digital contact tracing. And my contribution really to this work was mainly making it accessible. So this is a screenshot of a Shiny app. I don't know if any of you are familiar with these, but so I use the R programming language, and within that you can build these apps. So there's no coding and no formulae in sight anywhere. It's all just these nice slider bar things, so that anybody can essentially run your equations and play with the parameters within your equations to see how that changes the output. So seasoned mathematicians might be able to look at a formula and think, well, if I raise that parameter, then the overall result is going to do this. And policymakers aren't necessarily going to be able to do that. So because we were dealing with such early data, because there was such uncertainty, we wanted to be able to show, look, if you disagree with our assumption on exactly what the incubation period is, you can change it and you can still see what our conclusions are. And our conclusions were, so along the bottom here is % success in isolating a case, an infected person. And you can see that even if you completely successfully isolated everybody who got to the stage of their infection where they would show symptoms, that wouldn't be enough to bring the epidemic under control. You'd still need to be doing contact tracing and successfully isolating about 30% of their contacts. And that if you reached a sort of 60% success rate in both strategies, you might actually bring the epidemic under control with just those two strategies. And then the really important slide right at the top here is the delay, the hours from realizing that somebody's got it to quarantining their contacts. And I haven't done a live version of this because I thought it was too complicated with the screen sharing and everything. But if you slide that slider along, you can see that this threshold quickly moves up, and the delay is really detrimental to containing the epidemic. So we used this Shining app to convince policymakers that this was worth doing. And yes, so I vaguely mentioned there that you would need kind of 60% success in both to contain the epidemic. Please don't get the wrong impression. I was never advocating that those are the only strategies we should do, just saying that it's kind of surprising how much of an impact those two alone could have. And then if you mix them with other interventions, it can be quite powerful. And the way I think of these public health interventions is as a toolkit. So you've got all these different tools, and probably some I've missed, for attacking the epidemic. And it varies over time. Obviously we didn't have vaccines at the start. It varies with perception, public opinion, how willing they are to wear masks or that kind of thing. And the relative impacts vary over time. So if you've got everybody locked down, you don't actually particularly need them to wear masks. If everybody's moving around more, then you do. And similarly with contact tracing, if everybody's staying at home, there's minimal contact tracing needs to happen. So they all kind of vary in relation to each other. They vary across geographies and demographics. So I'll tend to be talking about England and Wales because that's where the NHS COVID-19 app is available. And even within those, uptake of vaccines hugely varies, uptake of the app hugely varies, and some of these aren't available for under 16s, under 12s, etc. So you do need a whole toolkit of interventions for different scenarios. There's an interdependence between them, which makes it really complicated to analyse them. So, for example, at the moment, all our contact tracing is triggered by testing. So you need your testing to be happening and to be fast for that to be effective. And then, of course, when you change, so now contact tracing is triggered by LFD tests. It wasn't before the 11th of January this year, I believe. So all of that, this picture keeps changing. But the success or failure of one thing can lead to you having to have more or less reliance on another. And essentially, your last go-to, if all the others aren't really working, is lockdown. And in general, you're trying to prevent that and go with, each of these has its own downsides, and you're trying to pick your favourite, least harmful ones whilst containing the epidemic. So they all chip away at the reproduction number R, some more than others, and in a really time-varying, confusing way. But if you have that in the background as I talk, hopefully that will help with the context of what I'm trying to analyse here. So then, very quickly, in April 2020, so this was members of the Fraser Group. I was at Oxford at the time, the Big Data Institute. We repurposed an agent-based model. I don't know if you're familiar with agent-based models. These are computer simulations where you've essentially got like 1 million people and you're going to track them, and you have them each kind of moving around each day in household networks and workplace networks and random networks, and you look at how the virus spreads, and then you can add an intervention and see what happens, and it all runs very quickly, so you can run it millions of times with millions of different interventions and see what happens. So it was repurposed from an HIV model, and it's now available as the epidemic COVID-19. It's open source, and it's being used by the NHS to inform admissions and bed capacity stuff now. But in April 2020, we were using it to examine different ways you could set up a contact tracing app. So, for example, do you just get the initial contacts, or do you get the contacts as well? Do you have it triggered by symptoms? How many false positives would you get that way? Should you do it based on tests? What about if there's a delay to test results? And we were just running all these different simulations for all different app uptakes and seeing what difference it could make to the wave as we came out of that first lockdown. And in each situation, you needed to quantify how many cases, hospitalizations and deaths you'd get, but also the number of people you'd require to be in quarantine, the number of tests you would need, and so on. So obviously, if you contact trace a few generations, you can end up being in a near lockdown situation. So you've got to balance how many cases you're averting with how many people you're asking to quarantine. Yes, so we were advising NHS X on that, and essentially I've remained an independent scientific advisor for the app ever since. Okay, so let's talk then about the impact. Has the app really done anything? Well, it was first rolled out on the Isle of Wight in May 2020, and we looked at the progression of the epidemic on the Isle of Wight and compared it to the other 149 upper tier local authorities of England. And it's a little bit tricky to compare because the Isle of Wight kind of went later with its epidemic surge, but we did various comparisons, including a synthetic control comparison, and it came out a statistically significantly different outcome on the Isle of Wight from elsewhere. And in fact, it went from having the 3rd highest R rate beforehand, before the launch, to the 12th lowest afterwards. It was a really fast drop in the case numbers after the test and trace launch. But that launch was testing. PCR testing became available. There was tracing. There was a huge advertising campaign. There was massive buy-in from local community leaders. There were people knocking on doors. It was a really big campaign, and we had no way of extracting the app's role in the sense of that wider toolkit of interventions. But I mean, it looked promising, but yeah.
Excuse me.
Yes.
Weren't those campaigns going on in all the other parts of the country though?
No,
Just
no,
in the Isle of Wight?
It was, I think it was like 5th of May on the Isle of Wight, and then 17th of May, I think widespread PCR testing came out elsewhere, but there certainly weren't the local campaigns and the door-to-door stuff.
And upper tier means the most populous ones, or what does that mean? You say the upper tier authorities, the 150. These are the biggest ones.
Well, just every postcode belongs to an upper tier local
Oh, so this
authority.
is this complete country. I mean, England it works. I see.
That's right. Yes. Yes. So then, after a bit of tweaking, the app was finally rolled out nationally across England and Wales. Please excuse me if I say nationally, I always mean England and Wales, in September 2020. it's hard to assess the precise impact. As I say, it's often confounded with other things, but also particularly because a large part of the design process for the app was that it should be privacy preserving. It was felt that to drive high uptake, people had to be able to trust that the app was really completely anonymized and private, and all the source code for how that works is online, and it's been really scrutinized. And I mean, it's so privacy preserving that I find it hard logging in to get the data. And there's no linkage in the data. So the sort of data we get is kind of daily, you know, the app on your phone kind of goes, I'm here, and then my user tested positive, or my user's got a notification. But we can't, for example, if I got 10 lateral flow tests in 10 days in a row, and each time I uploaded that positive test, you can't link it and see that it's the same person getting 10 positive tests. And you can't see whose positive test caused whose notification. So there's a lot of guesswork and statistical wizardry involved in trying to pull anything out with much certainty. Nevertheless, in early 2021, we were able to publish, so it's a Wymington-Ferretti paper in Nature, and we were examining the autumn-winter wave of 2020. So that was, if you remember, sort of September, October, November was all the TIAS system, and then the alpha wave kicked in late November. And during that period, so we used two different methods for estimating the number of cases averted. And by a modelling method, it seemed like it was around 284,000. And by a spatial comparison method, which I will tell you a bit more about later, it seemed like it was nearer 600,000. You can see the wide uncertainty on those estimates. But it does seem like, if you compare that to the, I think it was 1.9 million actual infections recorded, it seems like the app helped to reduce the size of that wave by between 14 and 24%. And it's really dependent on uptake. So what we did by comparing the uptake in different areas and matching areas on demographic characteristics, you could see that for every 1% increase in users, that led to a sort of 1 to 2% reduction in cases. So for anybody who was using the app, and particularly if you got a notification and you stayed home, thank you. It did take the edge off that wave a bit, albeit it still ended up being a very nasty wave. So when we talk about epidemiological impacts, there's lots of different ways of looking at them, lots of different things to quantify. There are what we call the indirect effects. So those are things like the app simply makes it slightly easier to order tests, slightly easier to receive your results. You can get local error information, these kind of soft impacts, but may well be helping people deal with the epidemic. I think there's a really interesting behavioural question, which I've not really seen anyone look at, but I wonder to what extent it actually has a preemptive effect. So if you know you've got the app switched on, and you know you've got an important wedding in 10 days' time that you want to be able to attend, what do people do? Now, one option is you turn the app off. And another option is you take extra care in those 10 days not to get pinged, to stay home a bit more, only do your essential contacts. And I don't know, I have honestly no idea how people behave knowing that they've got the app switched on, or whether they even just forget they've got it switched on. But I think that would be a really interesting thing to quantify if anybody's interested. And then there's this peculiar network effect of it can quarantine people who aren't infected, but if they hadn't quarantined at that moment, they would have got infected, right? That's not the typical thing that we're trying to achieve with contact tracing. But, bear with me, let's suppose Nicola and I get the same bus to work every day, okay? And Nicola's a good girl, she's got the app switched on, and I don't. And somebody on our bus route is infectious, has the app, and yeah, they register their positive test in the app. Nicola gets pinged. I don't. Now, if it turns out that Nicola had actually got infected by this person, then it would be, oh, brilliant, the app's worked well. If she hadn't been infected, you might say, well, that's a false ping, a needless ping. But actually, if she hadn't got pinged and we carried on getting the bus every day, I'm now infected by this common contact, right? And if we carry on getting the bus with me every day, you might get infected by me. And weird thing that the app does is essentially says, if you're willing to self-isolate for 10 days or take 7-day lateral flow test, now is a really good time to do it, right? It's circulating in your close contact network, and now's a really good time to hunker down. But that's a very strange one to quantify, but it's a really important fact. We saw in our models this strange effect coming out, and we couldn't quite understand it to begin with. It is actually quite a large impact of how the app works. And then there's the direct effect, the way that you'd expect it to work, which is that people who are infected get notified and they self-isolate. But I have to add the clause before they realised another way, right? If they only get pinged a day after they already realised that they had COVID, then it's not actually happening at all. So the direct effect is in that period between being infected and finding out another way. The app tells you something and you have an option to change your behaviour. And then there are broader effects. So for each case averted, well, they might have gone on to infect other people. So you've technically broken a whole transmission chain. And weirdly, therefore, the app has a greater effect on the start of a wave than on the way down. And the higher the app's specific impact, then the less reliance is needed on less desirable tools in the toolkit. And I'll speak more about that later. Okay, but for now, I'll focus on this direct effect and how we can measure it. So the direct effect size of the app, the number of infected people who get notified in a timely manner, is proportional to the number of exposure notifications that go out per index case, per positive case. And that can be controlled by the sensitivity of the app and also just by national contact rates, how much people are moving around. By the proportion of those who are notified who are infected. So if it's getting lots of false positives out there, that's not what you want. And then the average reduction in infectiousness upon being notified, so how much people actually change their behaviour. And as I was just saying, in fact, on the previous slide, the fraction of the infectious period that occurs after your notification and before you went down with symptoms and booked your PCR test and whatever it may be, otherwise lateral flow. Okay.
So here's the question.
Yes.
How do you tune this sensitivity? I mean, if I pass somebody by in the street, I mean, outdoors, I'm unlikely to get infected within a few seconds. If I stand next to them on the bus stop for a minute, maybe more. If I sit next to them on the bus for 10 minutes, much higher. How did you tune that?
That's right, thank you. It's a good question. So just in case anyone can't hear, how do you tune the sensitivity of the app? And the answer is, I'm not going to go into it in detail, but there's a risk scoring algorithm that basically takes into what's the word I want? It takes into it consideration. Thank you. The proximity, the distance between the two apps, the duration, the length of time you spent. It sort of checks every sort of 3 to 5 minutes, and you need quite a few of those. And also how, for the person who tested positive, how long did this contact happen before they tested positive? And so those factors go into a risk algorithm, and then if you cross a threshold on the risk algorithm, that's when a notification gets sent out. It's sort of loosely based on the 2 meters per 15 minutes within 2 days of a positive test or symptoms, but it's a bit more refined than that. Yeah. So there is publicly available data on the app available at this address, and I've made a little shiny dashboard, of course I have, that's what I like doing, that takes some of that publicly available data and puts it in some nice interactive charts to explore. And so I'm going to whiz through these fairly quickly, but this is the positive tests that get registered in the app divided by the number of positive tests nationally that week. And really all I want to say about this slide is that, you know, it's somewhere in the kind of 20 to 50% region. It changes over time in response to policies and the national picture. And then this surge at the end, it's a bit hard to tell, but that might be to do with the thing I just said about registering lots of successive lateral flow tests, because we can't tell if there's the same person might appear in the numerator of that a few times and then they don't appear in the denominator. So it's a bit hard to tell what that one means. And then this one is the same thing, but the denominator is cases amongst only the people who are age 16 and over, because under 16s aren't technically eligible to use the app. So that's kind of a slightly fairer comparison. And then you can see, I mean, with all the caveats and things I've said, but I think engagement with the app is quite reasonable. You're getting quite lots of people, even if they don't necessarily have the app installed all the time, do seem to be fairly easily convinced to register their positive test through the app. And I'll draw your attention to, in June, July, we were hitting over 60% of all national positive tests were getting registered through the app. Here, so the orange line here is the same thing on a log plot, and then the blue line is the number of app notifications that go out. And you can see it really tracks the stages of the epidemic. Sorry, I should say we're only going from December here just for technical reasons that some of the background stuff in the app changed how it measured things. So it's properly comparable from December of 2020. Sort of the notifications do kind of track the positive tests, but there are times when the gap between those lines widens. And we can see that in another way by plotting notifications divided by positive tests. We call this NPIC, exposure notifications per index case. And there you can see that for every positive test getting registered through the app, through this kind of heavy lockdown period, you're only really sending out 2 or fewer notifications. But in June, July, when there was lots of mixing and football matches and things, you were getting people sending out lots of notifications per positive test. And this is when you got talk in the media about the epidemic, because lots of notifications were going out. But this, I'll come back to, this is actually quite an interesting picture of national contact rates, how much people are moving around. And just finally on this bit, we can compare the number of notifications per index case from the app with the manual contact tracing service, the traditional one. And there you can see that they really do play complementary roles. So here in this period, this was where there wasn't all that much virus around, but where there was, you were getting surge testing and surge tracing. They could really focus in on local areas and engage with people. And there they were identifying many more contacts per case. And then, but then as case numbers rose, as the Delta wave kicked in, there's kind of limited capacity with the traditional system. And that's where then the app's scalable system kicks in and you're able to notify a lot more people. So yeah, that brings us back, I think, to the idea of it being a toolkit and these things all working in harmony with each other. So another component that we need to take into account for the direct effect is the proportion of those notified who are actually infected. that isn't publicly available information. It's something that we work out in the background with a Bayesian calculation. We were allowed to publish a little snapshot of it back in August last year. You can find this blog post if you're interested, which goes into a bit more detail on it. And you can see from this snapshot, it's another one of these things that changes over time. But in June, July, when we published a short analysis, of all the people reporting a positive test through the app, around 15% had already been notified and asked to isolate. So that gives you some sense of to what extent the app was managing to stay a step ahead and notify people in a timely manner. And then these are very difficult to measure, and so we put them in as different options in our equations. I'll show you in a moment. Essentially, the direct effect size is given by the number of notifications multiplied by the proportion of those notified who actually are infected, multiplied by the adherence, how much they change their behaviour, how much they reduce their contacts, and some sort of delay. You're presumably never going to be able to notify people the moment they get infected. So you have to ignore that first bit of the curve when they didn't change their behaviour, or they had no opportunity to change their behaviour because of lack of information. And using that definition and some different assumptions on adherence, so that's how well or otherwise people change their behaviour. You know, if people absolutely perfectly quarantine themselves as soon as they got a notification, then you'd be looking at, coming up for 60,000 cases averted. And this is just in the Delta wave. As you can see, very little happened to begin with. And then as cases started soaring, the app kind of has more opportunity to work. And it was concentrated just in a few weeks there. Tens of thousands of cases were averted. It's hard to know what a realistic adherence level is. There have been some ONS surveys that say it's around 80%. Personally, I think that it sounds high. I think the sort of people who will fill in an ONS survey may not be representative of everybody gets an app notification, but I don't know. If you installed the app, maybe you were up for isolating. I don't know. But even if it's only 20% adherence, you're looking at knocking a bit off that R number in that way. And so we did an analysis of just really that bit when cases were soaring in the first 3 weeks of July, and we found that every day somewhere between 2,000 and 6,000 people were getting notified who were infectious. And we reckon based on that the app directly prevented between 15 and 30,000 cases just in those 3 weeks. Or if you allow yourself to think in terms of transmission chains averted, you just think for each of these cases averted, how many people might they have infected? And we'll stop there, we don't carry on indefinitely, but if you stop there, you're looking at more like 50,000 cases averted, which translates into 1,500 hospitalizations, something like that. So within just 3 weeks, but yes, that was a real peak time of app activity. And we have looked at things since then, and we hope to publish them soon. Unfortunately, they're not ready for sharing yet. So yes, that kind of leads me into talking about the broader effects of each case averted. You've got a whole transmission chain averted. How do you involve that in your calculation? The Nature paper I referred to earlier does do that. And this point about the higher the app's specific impact, the less reliance is needed on less desirable tools. So at the height of that pandemic, cases were really, really high. And then suddenly cases dropped again. And I'm sure it was a combination of school holidays, adult holidays again, and there could well be all sorts of other effects. I think the app played a role, right? And I think it'll be really interesting to try and quantify how much of a role it played in the sudden downturn of cases that we actually saw in July. And if the app's input helped us avoid another lockdown or something, then of course the impact is much greater, but it's really hard to quantify. And there is certainly a school of thought that it did act almost like a targeted circuit breaker. So amongst all the people who were mixing who had COVID, they kind of all got told to stay at home all at the same time, and cases shot down for a good couple of weeks, and then kind of came along again, which might be commensurate with that hypothesis, but we don't know. So there are challenges really to extending this analysis since then. Anything beyond calculating that direct effect has become increasingly challenging. Part of that is that vaccines are doing all the heavy lifting, vaccines are brilliant, and vaccine uptake is strongly correlated with app uptake, so it's a bit hard to tease them apart. The Nature paper relied on looking at app uptake in local authorities and total cases in local authorities. Because that was done during that time of tier 1, tier 2, tier 3 restrictions, we could make quite strong assumptions about a positive test in one local area relating to a notification in the same local area, because people weren't moving around very much. And now that people are moving around a lot more, it's much harder to link those things together, and some of our assumptions break down. The advice keeps changing, so from August, instead of being asked to isolate if you were between 16 and 18, and or if you were vaccinated, you no longer had to isolate, you were advised to take a test. Just recently that's become take 7 daily lateral flows, so the picture keeps changing. But we do have estimates of cases averted for the first year of the app, which we hope to publish soon. And increasingly, we're just relying on sort of proxies for effectiveness, which are essentially how many users, how many positive tests are going through, are there still notifications coming through, and those kind of daily proxies. Okay, I've run on a bit. I've just got 5 minutes more, if that's okay, to talk about the epidemiological insights that we actually get back from the app. So the primary purposes of the app, of course, are to access information, check your symptoms, book your test, and these, as I've explained, reduce your chances of becoming infected in the first place and reduce your chances of infecting other people. But there is a secondary impact of surveillance. So I've already explained about how you can see the national contact rate going up and down as you see the number of notifications per index case changing. And we developed a measure based on that and based on the proportion who do turn out to be infected, that we get a sort of indicator of the national R number out of the app. So that's the one in red here. And when we were looking at it in February through to sort of April, it was really doing very little, and we were trying to see if there's any correlation with the national R number, and it was very hard to spot anything. And then suddenly, with the reopening in May and the Delta wave hitting at the same time, suddenly our measure soared upwards. And now this is the confusing bit. It's a lagging indicator because it only ever looks at infections that have been happening in the past week or so, but it's a leading indicator in the sense that it's available sooner than. So this is just a relatively naive estimate of the national R rate just based on cases. So we saw this surging up, and like a week later we could see the surge in the national R rate following it. And then, so when we published this on the blog in early August, it was going straight down at the end, and we thought that was a bit weird, but okay. And the following week, the national R rate also plunged. And this sort of data from the app has been providing really valuable insights into progression of the epidemic because it's available immediately. Phones just kind of send their packets that day. And so we can analyze this real-time data. And in my role as an advisor, we've been asked to make lots of really rapid analyses to feed into policy decisions. So things like, if we change such and such, how many tests are we going to need to support that, and so on. And it's also given us some epidemiological insights about what types of contact are the highest risk, which I don't think we would have any other way of finding out. So again, we hope to publish that very soon. So in summary, the NHS COVID-19 app has had a big epidemiological impact on the epidemic in reducing cases, hospitalisations and deaths, and in providing useful surveillance information and insights. I think it's going to be really interesting to see where it goes next. Obviously, it depends where the epidemic goes next, and what future uses there could be for the app, or whether it should be turned off, are all kind of up for debate in the near future. But I sort of hope you'll sort of stay engaged with the question. Please use it. It's really an important part of the toolkit. And it only gets, if you're vaccinated, you only get directed to do 7 daily lateral flows. And it's still a really relevant and important part of the toolkit. Okay, so thank you.